Hello everyone, and this is my first video on a respiratory topic, asthma. It's my first video. I want to clarify that I am nothing more than a medical student to begin this video. This is something that I'm doing for my own learning and maybe for your learning if it's something that you will find useful. I am doing this because I have spare time and I think it's a good resource to create. I've tried to reference all of the information that I'm going to use in this video in the comments or the description box below the video, and if there are any mistakes, there might be some mistakes, just write them in the comments and someone will correct it. I'll change what I can, and it's just meant to be a resource. Okay, that's the first thing. Secondly, I want to say that this is for my own learning. So I'm getting a call. One second. Yo, bro. I'm gonna call you. Yeah, I'm gonna call you back. Yeah.
Alright, bro, see ya.
Alright. Yeah, I'll just keep it in so I don't waste time. I'm not gonna edit any of these videos. It's just one take. I've made the PowerPoint. It took me around 4 hours to make, 3-4 hours. Some things might be wrong. I'm nothing more than a medical student. I'm not saying I'm a professional at this or an expert at this. It's meant to be just a chill and an easygoing video. I've got a semi-professional mic and I'm not representing any uni organization. I'm not affiliated to anyone or anything. I'm prone to mistakes. Do let me know if I make mistakes. Do I have anything else on my notes? And yeah, on a real note, I tried my best to make it as accurate and useful as possible, so don't come at me for anything that I say. But yeah, let's start. So today's topic will be asthma. Okay, something very common and something that a lot of people have. Let's start with the definition. Asthma is a chronic inflammation of the airway. It's a heterogeneous condition. By the way, I do mispronounce some words. If I do, let me know. I'll Google them later. Well, what this means is that there's a lot of conditions, a lot of things that go into asthma, right? And they all present differently. And it also means that everyone will respond differently to the treatment of asthma. The symptoms of asthma include coughing, wheezing, chest tightness, shortness of breath, that's what SOB stands for, limitation in expiratory flow, and stridor, in fact, which goes in with the wheeze that I've got there. And symptoms can get better or worse randomly, and it can sometimes just disappear for months at a time. It's kind of one of those like random things, and it can get quickly worse. It can get severely worse suddenly, and this is where you have acute asthma exacerbations. In this video, we're going to go through different things like how to manage this, how to investigate it, in a chronic setting, in an acute setting, in a long-term or a short-term setting. And to be honest, this is a informational video that a lot of people can use. I try to get information from reputable sources only and not just random websites. So it is a resource that anyone can use if they want to learn about asthma. So the risk factors for asthma includes, well, first of all, we need to get a good history from the patient and the family history of atopic diseases. Okay, atopy is the main risk factor that you can see in exam questions commonly and also in real life. Atopy is the predisposition to respond immunologically to diverse antigens or allergens, leading to CD4+ or T helper cell differentiation and overproduction of IgE. So the clinical consequence of this is that you will have a hypersensitive reaction to things like allergens or certain chemicals, and yeah, I mentioned T helper cells, T helper 1 cells. I mentioned T helper 2 cells in this situation. Just to remind you guys of the difference, T helper 1 cells are generated in immune responses against intracellular parasites. And these are things like bacteria, viruses. I guess these are things like pneumonias, of the lung, infections of the lung in different ways. T helper 2 cells generate immune responses against extracellular parasites. These even could be helminths, and atopy and allergy are, by the way, different. That's also something I want to clarify, right? Atopy is an exaggerated IgE mediated immune response, and an allergy is and all atopic disorders are type 1 abscessing disorders. An allergy is an exaggerated immune response to a foreign antigen, right? Yeah, the difference is atopy is more to do with the IgE response, and allergens is an exaggerated immune response to the foreign antigen, regardless of any mechanism. Atopy just includes the IgE. Now, atopy involves asthma, allergic rhinitis, allergic conjunctivitis, and eczema. The way I remember this is conjunctivitis. Okay, so first of all, conjunctivitis. Conjunctivitis is the swelling of the conjunctiva, which is the tissue that covers the insides of your eyelids, as well as the white part of your eyeball. Now, and the inflammation of the inside of your nose is what we call rhinitis, and eczema is, another word for eczema is atopic dermatitis, which is the inflammation of the epidermis and the dermis layers, right? It's different to cellulitis. Cellulitis is a bit lower down. Dermatitis is the outer layers of the skin. So that's something to clarify. And the way I remember atopic diseases is basically an inflammation of the outer layers of your body, right? It makes a lot of sense. So for example, eczema is the outer layers of your skin. So dermatitis, cool. Allergic conjunctivitis is the outer layers of your eyes and the conjunctiva, right, and your eyelids. Cool, that's the second inflammation. Allergic rhinitis is the outer layers of your nose, and asthma is the inflammation. We're going to go into the pathophys of asthma more, but it's the inflammation of the mucous membranes of your respiratory tract. So as you can see, it's all atopic diseases does is that the IgE response causes an inflammation of the outer layers of your body. That's what I concluded from this. Okay, so that's atopy done. Cool. Now I grouped together male and female together. That's something that comes up in a lot of diseases. You want to really look at if it's more common in males or females. Asthma is interesting. So males have more pre-pubertal cases of asthma. A lot of boys, in fact, they grow out of asthma, but females have a more persistent, they usually have more persistent cases of asthma. Interestingly, prenatal exposure to tobacco smoke and even later exposure to tobacco smoke can be a risk factor for asthma too. Now, talking about exposure, it's also important to realize that this could be exposure to particulates, or it could be workplace exposure. Now, the difference between particulates and workplace exposure is this. Now, the way I think of it is particulates are very small molecules that are microscopic, and they don't have to be solids. They could be liquid droplets, and they have serious health problems associated. The thing about work exposure is it could be from flour dust. You get baker's asthma, or you get isocyanates, which isocyanates is a chemical in paint. You will hear this a lot in things like asthma. It's an irritant for the skin and the mucous membranes, and isocyanate basically makes paint more durable. So if you're wondering why we use isocyanate, if you put paint with isocyanate and you paint your car, it makes the paint stick onto the car a lot better. Okay, fine. And yeah, so you have flour dust, you have isocyanates, and then we have resp infections at childhood, right? And then we have weight. So weight changes again. Premature birth associated to low birth weight is a risk factor for asthma, and obesity also is a risk factor for asthma. So those are two things. And finally, I want to speak about social deprivation. So this is mainly to do with poverty. Always something to ask yourself with every condition, because social status and social, they talk about the socio-economic factors are very important in the prognosis and the development of a lot of diseases. And the reason being is in asthma is probably because if you live in poorer households, you're more likely to be living in damp housing with fungal spores, pollution, and exposure to tobacco smoke. We already mentioned tobacco smoke as a risk factor. So it all ties in, and it's something to keep as a broad picture. So I know this is a long list, but when you think about it, they all fit in together quite nicely. Now again, differential diagnosis. It's just a long list I've got here, but I'm going to try to talk through everything as well as I can. So COPD, the idea with differential diagnosis is that with asthma you have coughing, wheezing, shortness of breath, and with these conditions you might have it might look similar in clinical presentations. So COPD is basically a mixture of bronchiectasis and emphysema. That's something I'm going to cover more in a later video. Ciliary dyskinesia is a congenital thing where you have inflammation and persistent cough from birth. Cystic fibrosis is another congenital thing which causes persistent moist cough and GI symptoms. It can also, unrelated, can cause finger clubbing. Finger clubbing is chronic hypoxia. Cause finger clubbing because the micro vessels in your fingers and your fingertips, there's really small vessels here, they start to dilate. So you see this a lot, you see clubbing a lot in smokers, for example, and of course in cystic fibrosis here. And you have failure to thrive in children. Dysfunctional breathing, this is just breathlessness, dizziness, lightheadedness, and peripheral tingling. This could be caused by a lot of things. Foreign body aspirates, so this could be sudden onset cough, stridor. Stridor is very common in asthma. That's something to check out for in OSCEs, when doing a resp exam with the initial inspection of a patient. And bronchial breathing, bronchial breathing is where you exhale for a longer time than you inhale, than your inspiratory. And what it ends up sounding like is a harsh sound, a reduced diminishing breath, and interestingly, stridor is an obstruction of the upper airway, and bronchial breathing is more of an obstruction of the lower airway. Okay, so that's something to also keep in mind. Again, GORD causes coughing, vomiting, postural, and food-related symptoms. Heart failure, orthopnea. So orthopnea is when you lie down, you get breathless. And a good question to ask in OSCEs is, how many pillows do you sleep with? Do you sleep with more pillows recently? Have you started sleeping with more pillows recently? And this is a risk factor question to ask. Associated with heart failure, you also have edema, ischemic heart disease, and you can have fine lung crepitations. Then you have interstitial lung disease, which is a dry cough and fine lung crepitations associated to it. The causes for interstitial lung disease, we're going to cover this later on as well. It could be asbestos, so exposure to asbestos, asbestosis, or pneumoconiosis, which is the inhalation of dust. An example of this could be coal. So coal workers with pneumoconiosis can have black lungs. I need to drink some water. That by inhaling the coal mine dust, and this causes black lungs. I think it's called like black lung syndrome or something. And you can have fibrosing alveolitis, which is a weird gas exchange, and it's idiopathic. The exact reasons aren't known. I didn't go into too much detail in this. And what else do we have? So sarcoidosis. Sarcoidosis is a rare condition that causes small patches of red and swollen tissue called granulomas, and they develop in the organs of the body. You can have pertussis. So this is, I don't know how to pronounce that, but this is a whooping cough. It's very common. It's a bacterial thing. Children have it, and it can cause difficulties in breathing. It can cause almost like a, if I remember correctly, it causes a barking noise, and and it can make breathing quite hard for a child, so dyspnea happens. Pulmonary embolisms is when a blood clot gets stuck in the artery of a lung and again causes breathlessness. This can also cause pleuritic pain, right? So asthma causes chest tightness. This could cause pleuritic pain, slightly different. It can cause hemoptysis, so you're coughing up blood. It can cause crackles and sinus tachycardia. Sinus tachycardia is when the heart goes at a regular rhythm, but it goes a lot faster than it usually does. And tuberculosis caused by the Mycobacterium tuberculosis, and it causes a persistent productive cough, right? Productive because your mast cells are involved as an infection, right? And it can be associated to breathlessness and hemoptysis. 1 second. And you have upper airway cough syndrome, which can be caused by a various of conditions, but the two main ones I want to point out is chronic sinusitis, which is very common, nasal blockage or discharge with facial pain and pressure over your sinuses, or allergic rhinitis or rhinitis, which is nasal itching, sneezing, discharge and blockage. Now finally, we have vocal cord dysfunction. So how the vocal cords work is, imagine two strings. So they're usually open when we're breathing. How do I show the camera? And when we want to speak, these tighten up and we blow air between the two and they vibrate against each other and it makes a noise. Now, when you have the dysfunction, when it's meant to be open, because when we're speaking, the vocal cords are closed, and so we can't breathe and speak at the same time. That's one of the reasons, right? And we have to blow air. We have to blow air through these cords. Now, in the dysfunction, when it's meant to be open, it closes, and so what happens is it makes it a lot harder to speak, and also gives you breathing problems associated. And so this could be another differential diagnosis. Again, all my references for where I got these will be referenced down below. Now, epidemiology. I don't know, this is a coincidence, but a number to remember here is 12, okay? So, I try to make it easy. Worldwide, approximately 12% of children aged 6 to 7 get asthma. I'm in the UK, so 12% of the population in the UK has been diagnosed with asthma. Some have grown out of it, so 12% of the population have been diagnosed with asthma at some point in their lives. That's quite a lot. Out of 10 people, just over 1 of those people will be diagnosed with asthma. Some grow out of it, and over half of them are treated. Less than half of them are untreated, and maybe they haven't grown out of it, they're just unaware, right? Now, the etiology of this condition. The exact etiology is unknown, so we can call this idiopathic in a way. Some important risk factors include maternal smoking in pregnancy. We can also look at occupational sensitization, and so these two things are the really big two risk factors, as well as atopy actually, and they probably have something to do with it. In the past, avoiding animals and breastfeeding for longer was associated as, a reduced risk of getting asthma. Recent studies have pushed us away from thinking that. So this seems more unlikely than it has been in the past. So in the future, studies of epigenetics and gene by environment studies looks promising. Epigenetics is pretty much gene by environment from my understanding. So the way we live our lives and the decisions we make kind of have these micro effects on our genes that can actually be passed on. So that's why we see that gradually in Western or in modernized societies, atopy is actually increasing. Fine. Wow, teaching is hard. I don't know how lecturers do this, but we're gonna push through. Clinical features of asthma. So I've got 4 main ones. Shortness of breath. Sometimes it affects insomnia. If it affects insomnia, we're going to talk about giving long-action beta agonists and all the fun stuff associated with it. It can cause clinical chest tightness and pain. It can come with wheezing and a cough. And it can also come on with exercise and irritants and allergy and cold air. So the reason why exercise induces wheeze is because prolonged exercise or cold air, as I'm sure with also allergens as well, increases the amount of histamines, prostaglandins and leukotrienes in your airways due to mast cells. So the mast cells release all of these things, so histamines, prostaglandins and leukotrienes, and also stimulates your neural reflexes, and this causes an inflammation, which we're going to go into why this is significant in a bit, because we're just doing the pathophys in the next slide. And coughs can be worse at night if not controlled. I'm not sure exactly why, but that's a fact. So the pathophys of asthma exacerbation. I'm thinking maybe we should start from the last thing. So last point here. Let me see if I can draw actually. Let's make this more engaging, right? So here. Oh wait. Okay, here. Alright, so let's start with this point. We need to treat both bronchoconstriction and inflammation. Now, there's two stages, early and late phase. The early phase, IgE antibodies are sensitized and released by plasma cells due to risk factors. IgE, it has a high affinity to mast cells. So plasma cells release IgE, IgE binds to mast cells release mast cells and basophils, but mainly mast cells, to concentrate on. Mast cells release cytokines, then degranulate and release histamines, prostaglandins, leukotrienes, and this tightens your airway, right? Now, I spoke about interleukins. Now, interleukins can sustain the inflammation that's caused. But also, interleukin 13 can be involved in remodeling and fibrosis. Interleukin 13 can cause myofibroblasts to release collagen, which can then put your epithelial cells to transition to mesenchymal cells, causing a thickening of your basement membrane, and this can be irreversible. So even though asthma is usually a reversible condition, we're going to see later on that when diagnosing, it doesn't always have to pass the reversibility, the reversibility investigations with the bronchodilators, right? And then we have the late phase. So this is the early phase, IgE, all of this, tightening airways. The late phase happens a few hours later, again by the mast cells, and it contributes in bringing eosinophils, basophils, neutrophils, and also helper and memory T cells to collect in the lung. Now, first causes bronchoconstriction, as it does before, but then it causes an inflammation. So these are the two things that it causes, right? Very important to remember, because these are the two things we are going to manage later on. But before we manage, we want to investigate. Now, this part can get a bit confusing, but I'm going to try to help as much as I can. So there's 5 main investigations to do, right? The first investigation we start off with is actually there's 6. First of all, they come in with a history of symptoms that seem like asthma. And then we do a spirometry. In the spirometry, we're looking for the FEV1 to FVC ratio, right? Let me check something quickly as well, my notes. 1 second. Yeah, so asthma is an obstructive disease. What this means is the best way, this is a very simplified way of looking at this condition, but if we were to have our lungs, I always imagine obstructive to be as if we have something obstructing the airways, right? It doesn't really affect the lungs, but it obstructs the airways. So what this means is when we're breathing out, less air can move past. However, the full volume of this place kind of stays the same. Now, forced expiratory volume in 1 second, is reduced because there's something obstructing. However, the forced vital capacity, which means the full, kind of like the whole area here, the full volume here, kind of stays the same. So this means that the ratio reduces below 70% of what it's meant to be. If it does, then we have an obstructive disease. And as soon as we know it's an obstructive disease, we try to check if it's a bronchodilatory disease, if it's reversible by bronchodilators. So if they're 17 plus, with the bronchodilator reversibility test, the BDR test, we give them bronchodilators, and we want to see an improvement of 12% in their FEV1 and just 200 plus milliliters of improvement in volume increase. If the patient is between the ages of 5 to 16, just an improvement of 12% in their full forced expiratory volume is enough to say that this is positive. Okay, this is a positive finding for asthma. Now, we also have the fractional nitrous oxide, right? So nitrous oxide shows us inflammation in the lungs. So over 40 parts per billion in 17-year-olds is positive, and between 5 to 16, you just have to have it has to be over 35, right? So not 40. And you only do this if normal spirometry or obstructive spirometry with a negative bronchodilatory reversibility test happens. And you have to be aware that some smokers can naturally have a lower nitrous oxide level. Okay, and remember that the number 12 for some reason is an important number. And again, we said 12% of the population in the world. We said that, so in the world, out of kids, 12% have asthma, 12% in the UK get diagnosed with asthma at some point, and an improvement of 12% in your BDR will be associated to a positive result. So 12, 12, 12, okay? Let me see if I've written anything else in my notes. And yeah, so FeNO is a check for the inflammation in the lungs, which is a part of what asthma really is, along with bronchoconstriction. So there is no one gold standard test for asthma, unfortunately. You need to have a thorough history and a thorough examination by clinicians, but there is no one gold standard test to do. You need to look for many. So this is where it gets a little complicated, because a lot of patients have diagnostic uncertainty. So I'm going to work through this. I've color coded it so it's a little bit easier. Imagine every patient that's come here has come with positive symptoms of asthma. Okay, so we have a patient with asthma symptoms. However, you do a spirometry, because remember, that's the first thing that I recommended doing. We do a spirometry on the patient, and they have a normal spirometry. So what do you do then? Well, then you can also, if you want to you can monitor their peak flow variability. Now, peak flow variability is where you there's a tube, and you might have seen this in uni. It's quite an easy test to do, and they blow in the tube and they see how much they can push a little bearing, a little ball, and it shows how much peak flow they have in one try. And a variability of over 20% is a positive finding over 2 to 4 weeks of treatment. Okay, so a negative BDR bronchodilator reversibility test will basically mean irreversible airway obstruction, and this we can see later on. So you might have an obstructive spirometry, so that's positive. So they have the symptoms, they have an obstructive spirometry, but then you check their nitrous oxides, and it's below 40 parts per billion. So that's not enough to diagnose someone with asthma still. Then you have to go back to this, and you have to monitor their peak flow variability. Or they might have the asthma symptoms and they have an obstructive spirometry, so again a positive. This time they have a negative bronchodilator reversibility test, right? And after that you have to do a NO. The FeNO isn't negative, but it's low. So it's below 39, but it's over 25 still. And also their BDR, bronchodilatory reversibility test, is negative. But then again, you do the monitor their peak flow variability and you see if it's positive. Now we're going to see the flow chart to how you can diagnose from there. We also have diagnostic uncertainty after peak variability. Well, that's one of them. And so the nitrous oxide in the patient after having positive symptoms might be over 40, so it's positive. However, they have no variability in peak flow, and they have no peak flow. Then instead of the peak flow variability, you can do a direct bronchial challenge with the PC20, right? The PC20 has to be below 8. Now this is harder to find than the peak flow variability. It's less accessible, the bronchial challenge test, but it's a test where you give them histamines and methacholine that will trigger their lungs, and you're seeing if they have a hypersensitive airway system. So a nitrous oxide of over 40 but no variability in peak flow will mean that you can do the direct bronchial challenge and you can see if it's positive or not. Now, if they have a nitrous oxide of less than 40, but then they have a variable peak flow, right? So it's positive variable peak flow, but the nitrous oxide is negative, then you can do it again. Or if they have the symptoms, they have an obstructive spirometry, but then they have a negative BDR, but then their nitrous oxide is a bit in the yellow zone, as it was above here, you know, between 25 and 39. Then again, and there's no variability in peak flow. So there's some evidence that they have asthma. Then again, the bronchial challenge, direct bronchial challenge, can help you determine if they have asthma or not. What this PC20 means is you're giving them these histamines and methacholine. In a normal person who's not hypersensitive, they can tolerate more than 8 milligrams of this mix of histamines and methacholine for their FEV1 to reduce by 20, right? 20% for their FEV1 to reduce by 20%. However, with someone with asthma, it takes them less than 8 milligrams of this mixture of histamines and methacholine to reduce their FEV1 by 20% because their body is hypersensitive to these things. And so the PC here really stands for provocative dose. So the provocative dose to reduce by 20% FEV1, which is the FEV1 is the main thing that's affected, that in obstructive respiratory diseases is less than 8 milligrams per milliliter. Cool. So here we have the nice guidelines. I've got the ones for children and I've got the ones for adults. I know it's quite small, so I'm going to have to look here. So this is between 5 and 16. You just have to remember the order that you do it in. So as I said, first of all, they come in with symptoms. Do a spirometry. If it's yes, do a reversibility airflow obstruction. If it's yes again, diagnose. If there is no obstruction but there's spirometry, so if there is obstruction but the reversibility airflow tests with the bronchodilator was negative, then you know that their FeNO levels, then you have to test their FeNO levels, which if their NO levels are less than 35 for children, remember it's not 40, it's 35 for children, then you refer to a specialist because they have an obstructive disease. However, it's not reversible, and you know their NO, nitrous oxide levels are low. A specialist needs to review this. However, if they do have an obstructive disease, it's not reversible. However, their NOs are high, then you have to do one more test. So you have to see the variability in peak flow readings, and if it is high, if it does vary, you can diagnose. If it doesn't vary, then because their NO was still high, you can suspect asthma, and you'll review with after you start treatment. At that point, you'll see if they're tolerating the treatment well or not. So remember that if there is no obstructive, this is so important, if there is no obstructive disease, you do not need to do a reversibility airflow test. Okay, no obstruction in spirometry means no reversibility test needed. You just go straight to the FeNO. If the FeNO is above 35, then again you have to see the variability in peak flow readings. If there is variability, diagnose with asthma. Easy. So if there's like two positives if there's like two positives, most times, two investigations that give positives, most times that's enough to diagnose with asthma. If the variability in peak flow readings is not there, then you have to suspect asthma because their NO levels were still high as before. Okay, same with the other side. So, but then if their NO levels are low, but their peak flow readings are variable, then again you can suspect it. So these ones can switch around. So either their NOs need to be high, variability needs to be low, or their variability needs to be high, but their NO needs to be low. You can suspect asthma and see after treatment. Of course, if it doesn't work, maybe you have to diagnose with something else or refer to a specialist. And if their variability to peak flow readings is still a no, you have to consider an alternative to the treatment. These are kids. Adults are pretty much the same actually. I know it looks different, but the only difference is there's more steps in each section. So with kids, you can kind of skip the variability or etc. But here, obstruction, yes, okay. There's an obstruction. We need to do reversibility test, remember? So reversibility test, yes, then that's not enough. We have to do an NO test as well. If that's yes as well, they have asthma. Finished. Reversibility test, NO is negative. Then you have to do a variability in peak flow. You have to check the variability in peak flow readings. If that's positive, again, they have asthma. If there is no variability, but their NO levels are still kind of within the range of 25 to 39, you can suspect asthma and you can review after treatments. But if their NO levels are less, then you have to consider an alternative treatment, as is indicated. Maybe I should show you here, as is indicated here. All right. So airflow obstruction. So obstruction, yes. Reversibility, no. NO levels, yes. Above 40, yes. Asthma, if it's below 40, then you have to ask yourself, is it between 25 and 39, which is not something we do for kids. If it is yes, is there variability in the peak flow readings? If it is yes, suspect asthma and review. If it is no, is there airway hyperreactivity, right? This is really important. So it was yes, but then it was no for the variability in peak flow. Then we check if there's airway hyperreactivity. If it's yes, you can diagnose with asthma. If it's no, then you have to consider alternative diagnosis. If it's no, consider alternative diagnosis. Again, obstructive, no. Are FeNO levels 40 or more? Yes. Is there variability in peak flow? Yes. Diagnosed with asthma. Self-explanatory here anyway, because there's more than two positives, as you can see, positive. So pick the wrong pen. We have a positive. Why am I'm just trying to pick the pen to write. Okay, yeah. We have a positive and we have a positive, so you can suspect asthma. If it is positive here, but it's negative in variability, then again, hypersensitivity, not something that's done for children. right? So you just have to remember obstructive respiratory, reversibility only for obstructive, FeNO, variability in peak flow, and then you do your hyperreactivity, and of course everything's negative, you have to consider an alternative diagnosis. Okay, I hope that made sense, but for most exams they won't go into the exact details of this. I feel like you just have to know what investigations to do at what point, but this would be useful in your clinical practice and when you start practicing properly to know exactly what you're gonna test for. Okay, this is something that you just have to memorize. Unfortunately, we have 1, 2, 3, 4 levels of acute asthma severities, right? It starts from moderate, so it doesn't start from mild, it starts from moderate for acute settings. Peak flow has to be between 50 and 75. No features of acute severe asthma, so that's kind of easy. It starts from 75 and it kind of goes down in points of 25, 30, because 75 to 50 peak flow moderate, 33 to 50, sorry, yeah, 33 to 50, so around 20 points here, shows as a severe acute asthma. If the resp rate is over 25, severe acute asthma, that's high. If heart rate's above 110, severe. Inability to complete sentences in one breath, severe. Life-threatening, so this is quite important because this is where we admit to hospital. Peak flow less than 33% of best are predicted, so okay, 50 to 75, 33 to 50, 33%. Arterial oxygen saturations are less than 92%. Partial arterial pressure of oxygen is less than 8 kilopascals. The normal partial arterial pressure of carbon dioxide is normal, right? Normal partial arterial pressure of carbon dioxide. And most importantly, you have a silent chest, cyanosis, poor respiratory effort, arrhythmias, exhaustion, altered conscious levels, and hypotension. Now, this sounds more severe, you're unable to complete sentences, but best believe if you're silent chest and cyanosed, that's a life-threatening level of acute asthma, right? And for these patients, 15 liters non-rebreathe mask, you need to get oxygen in them as soon as possible. As you can see, the oxygens are very low. Near fatal acute asthma, this is where you have literally, if the raised PA CO2, if the CO2 is above what it's meant to be, it means the patient is getting tired and there's CO2 retention. That is a very near fatal acute asthma, very severe case. Okay, acute asthma management, you don't need to learn too much detail, so just remember these 4. First of all, sit up the patient 100% O2 via non-rebreathe mask. You're aiming for around SpO2 of 94 to 98%. You're doing a nebulized salbutamol SABA of 5 milligrams, ipratropium, which is a short-acting muscarinic antagonist. We're gonna go through all the drugs, by the way, guys. You know, I'm not gonna let you guys leave before not knowing exactly what these are. Of 0.5 milligrams, yeah, you put a hydrocortisone or prednisolone, you know, just to take the inflammation off. If it is life-threatening, you have to involve the intensive care team. You need a magnesium sulfate of 2 grams IV, okay, straight into the veins. You need a nebulized salbutamol every 15 minutes. This is so important and something that can come up in exams. If no improvement again, keep going with the nebulized salbutamol. Keep going with the ipratropium that we've started here, right? And keep going with and then consider aminophylline, unless already on theophylline. Here you have to take them to ITU because there's not enough oxygen going to them and this could be a quick death. You need monitoring, or especially ABGs, and you need peak flow measurements every 15 to 30 minutes post salbutamol. You need to do O2, you need to keep O2s above 92, otherwise straight to ITU, right? ITU. And consider ABG measurements, as I said before. Okay, so it's all kind of self-explanatory, especially when you understand what these drugs do. You just have to remember to know if it's at what of the 4 stages of acute asthma it is, and you always do these first 4 steps, and then you do the next few steps depending on how severe their condition is, in that order. With chronic asthma, this is a summary of what we give. So you always give a short-acting beta agonist as required, unless they're on MART. We're going to go over all of this, by the way. And you can consider moving the dose up. You give a MART if they're using a short-acting beta agonist more than 3 times a week, but we're going to talk about this as well. So you start with a low dose ICS, and then you go to a regular preventer of low dose ICS. Then you add so you just keep adding. Then you add a long acting beta agonist if the short acting isn't working, and you keep on the ICS, which is a fixed dose or a MART, and then you increase ICS to medium dose, add an leukotriene receptor antagonist, and if no response to a LABA, consider stopping LABA. And finally, you do specialist therapies where you refer to a specialist care team. Okay, so just learn these steps pretty much. So you start with you always start with a short-acting beta agonist. You give an ICS. You add a long-acting beta agonist instead of your short-acting beta agonist if they're having, for example, symptoms at night, or if they're using their SABA too many times a week, and it goes up and up. Okay, so the non-pharmacological treatments of chronic asthma include smoking cessation, very important, the avoidance of extrinsic factors, and this thing called sublingual allergen immunotherapy I read in a book is useful in children which live in houses with house dust mites, and has shown a reduction in the number of asthma attacks. However, this is only seen to be useful in children and not adults, and you have to review the inhaler technique, of course. The aim with chronic asthma is that they stop getting symptoms. They have no nighttime awakening due to asthma, no need for rescue medication, no asthma attacks, no limitations on activity including exercise, normal lung function. In practical terms, this means a forced expiratory volume 1 or peak expiratory flow of over 80%, predicted or best. And there's minimal side effects from medication. Okay, so you need all of this to really know that you're keeping chronic asthma in check. So the prognosis, the early onsets in children usually are better prognosis. However, early onsets along with signs of atopy shows worse prognosis. Okay, most children with asthma and significant wheezing continue into adult life, and so most people have their brown inhalers, which is their corticosteroids, inhaled corticosteroids, the ICS, and they have their blue inhalers, which is their short-acting beta agonists. So these are the drug reviews we went through. This is kind of like we're coming to the end of this now, so we're just going to go through the drugs now that we've gone through. Short-acting beta agonists, the main example is Salbutamol. It's in acute settings. Even if someone has their blue inhalers, they only use it when they have their wheezing starts to come on again. You have the short-acting muscarinic agonists, like ipratropium, which is again in an acute setting. You have the MART, which is chronic. For chronic conditions, you have the LABAs. Salmeterol is an example of LABA. Again, a chronic treatment. If the SABA is not working, you have ICS, Prednisolone, acute and chronic given. You have LTRA, so the montelocast, chronically given. You have magnesium sulfate, acutely given. Remember the 2 milligram IV, and the 15 liters non-rebreathe mask. So again, we mentioned the oxygen masks, acute, and aminophylline if theophylline isn't already given, acute. SABA, salbutamol, is a blue inhaler. So the mechanism of action here is that it's a selective beta-2 receptor agonist without B1 activation. So what this means is you'll get a bronchodilation without tachycardia. It's amazing because B1 is found in your heart. The indication is for prophylaxis for allergens and acute asthma. By the way, there are some contraindications and indications that I've skipped, and I've only kept the ones that I thought were relevant for asthma as a condition. And the contraindications for salbutamol includes eclampsia. Eclampsia is like the severe complications due to preeclampsia, and beta blockers, because beta blockers block the beta receptors, and salbutamol bind and activate the beta receptors, so they do the opposite thing, they don't interact well together. And then interestingly, intrauterine infections and intrauterine fetal death, right? As well as, so that's two things about the intrauterine infections and fetal death, and also myocardial infarctions, so like a heart attack. Side effects include potential hypokalemia. I'm going to speak about hypokalemia in a future video. However, it's good to always mention or always note drugs which are hypokalemic, because if you're giving multiple drugs which are all causing hypokalemia, along with any other electrolyte imbalances, but especially hypokalemia, those are contraindicated with each other. So that's a way to remember without having to just memorize the list. It can also cause a tremor, so that's when we, in OSCEs we might say, could you please put your hand out and keep it as still as you can, and you're seeing if there's any tremors like this, or if they can keep it still. It can cause a headache, palpitations, or tremor. Okay, as I said, I've repeated tremor twice. As you can see, guys, I'm an amateur. Don't judge me, guys. Come on, we all make mistakes, right? Short-acting muscarinic agonists. Am I right? Is it an agonist? Antagonist via block. Okay, it might be an antagonist actually. So ipratropium is one. Acetylcholine antagonist via blocking of muscarinic cholinergic receptors. So it's an antagonist. Okay. Oh yeah, it is an antagonist. Blocking cholinergic receptors decreases the production of cyclic guanosine monophosphate (cGMP). This decreases in the lungs, in the lung airway, which will lead to a decrease contraction of the smooth muscles. I got this from here. I didn't really write so the references are all in the description. I just kept this part in, but there's another. So if I put in quotation marks, that just means I've taken it from a research paper, because it explains it really well and concisely in not too much detail. It decreases cGMP, and this makes it less, it reduces the contractility of smooth muscles. It's pretty nicely put. Indications for SAMA include COPD, bronchospasms, which can be allergy related, asthma or rhinitis, and contraindications include epistaxis, so that's nose bleeding, headaches or nasal complaints. Side effects: arrhythmias, constipation, cough. So the muscarinic effects are usually like constipation, dry mouth, they all go together, dizziness, I think blurred vision as well, headache, nausea. So we have the maintenance and reliever therapy, the MART. This is essentially a mixture of budesonide and formoterol. Budesonide is a corticosteroid, ICS. Formoterol is a LABA. And yeah, if you're using SABAs over 3 times or 3 times a week, or you're symptomatic 3 times a week or more, or you're waking up nights due to asthma more than once a week, you give a MART. I don't know if that sounds weird to say MART, I just mean, you know what I mean, guys, come on. And then you have the LABAs, the salmeterol. So the mechanism of action of LABAs is the pre-junction of beta-2 adrenoceptors and reduces the acetylcholine release. Therefore, it prevents any functional competition by acetylcholine and post-junctional muscarinic receptors in the airway occupied by LAMAs. So what this means is that it blocks the acetylcholine and it triggers the B2 adrenoceptors a lot more, essentially. And the indications for this includes nocturnal asthma, reversible obstructive disease, long-term therapy, exercise-induced bronchospasms. And remember, with exercise-induced bronchospasms, we also spoke about exercise-induced asthma, so they're all linked. Chronic asthma patients which also take corticosteroids are also, considered for LABA treatment. The contraindications include hypokalemia. So again, hypokalemia, guys, is something that I've mentioned before, and there's a lot of drugs, but I just wrote a few here. Like digoxin is given for heart failure, of course, and that causes hypokalemia. So digoxin doesn't cause hypokalemia, but it has a toxicity. But beclomethasone, budesonide, aminophyllines, these are things that are quite common. I just picked the common ones to speak about. They are, and furosemide, I think methadone as well, but they cause hypokalemia, so that's why they're contraindicated. And as you see these drugs, it's going to become more and more, well, for me as well, it's going to get easier to recognize what is hypokalemic and what's not. And then the side effects include, they're the same, pretty much the same as short-acting beta agonists. So arrhythmias, tremors, headaches, palpitations. Yeah. So prednisolone, ICS. I just focus on prednisolone here. They decrease inflammation via suppression of the migration of polymorphonucleosites and reversing increasing capillary permeability. It also suppresses the immune system by reducing the activity and the volume of the immune system, so it reduces inflammation. Okay, and it's given for things like COPD, acute exacerbations, croup. So I mixed it up with croup and whooping cough. The croup is the one where you have a barking sound, and it's a cough that's in children, unless they're the same thing. But yeah, I'm not too sure actually. Let me check. Actually, 1 second. Croup. Yeah, they're not the same thing. Okay, so I've got those mixed up, but you can give prednisolone and croup, and it causes allergic inflammation, and it can be given in allergic inflammation as well, because it reduces the inflammation. It's also good for idiopathic thrombocytopenic purpura, which is a decrease in platelets. It's congenital, and it can cause easy bruising, and it's an autoimmune disease, and actually can be mixed up with leukemia a lot of times, because you can have bruising that looks similar to certain types of leukemias, like ALL, acute lymphatic leukemias. and it's also given him an inflamed otitis externa, ulcerative colitis, and Crohn's disease and SLE. So contraindications, the main one to remember is avoid giving it for too long for the ear. I think it's bad because it can cause more infection, and side effects includes anxiety, Cushing's as you give more steroids, electrolyte imbalances, GI discomfort, skin reactions. With Cushing's you also have things like hirsutism, increased risk of infection, like as I mentioned, the ear, and an irregular menstrual cycle. Monteloclasts is the mechanisms is it reduces, so it blocks the leukotriene D4 in the lung, which decreases the inflammation and relaxes smooth muscle. Indication given as prophylaxis for asthma, allergic rhinitis, symptom relief, and contraindications includes phenytoin, rifampicin, and carbamazepine. Yeah. Side effects: diarrhea, fever, GI discomfort, headaches, skin reaction, upper respiratory tract infections, and vomiting. Sorry guys, I forgot to change that to white. This PowerPoint was on a background of white initially, and then I made it black, and then I tried to change everything back to white as in the text. But it's 1 o'clock in the morning and I'm tired and I made some mistakes. It's fine, first video, isn't it? Magnesium sulfate, mechanism of action: blocks calcium channels, decreases calcium availability, inhibits smooth muscle contractility. Indications: severe asthma, prevention of seizures in preeclampsia and eclampsia, hypomagnesemia, arrhythmias, rapid bowel evacuation. Side effect: paralytic ileus, especially during rapid bowel evacuation. When it's used for rapid bowel evacuation, if I remember correctly, it can cause this paralytic ileus, so that's something to remember. Maybe you'll use it, I don't know. 15-liter non-rebreathe mask using, I'll put this in bold guys because we don't want to be killing our patients. Using extremely low levels of blood oxygen, one-way valves, so you're only breathing oxygen from the tank. It's good for carbon monoxide poisoning, where your blood isn't able to hold on to enough oxygen as it used to be, because carbon monoxide binds onto those red blood cells and irreversibly binds on, and it's hard for real proper oxygen to hold on to those red blood cells, so it reduces your blood's capacity to carry oxygen. Trauma, cluster headaches. Apparently it's one of the most painful things and one of the most painful pains that a patient can have, but giving them a lot of oxygen in this way helps with this. Is one of the only things that help, I think. Aminophylline, mechanism of action not exactly known, but it's a bronchodilator. You can read up on the biochemistry. Indications: so severe acute asthma, COPD in patients not previously treated with theophylline. You can give in chronic asthma, reversible airway obstruction. Contraindications: acyclovir, so the antiviral, given for herpes and things. Beta blockers, amiodarone, again hypokalemia guys, so that's something to that's been a theme today, I think. Well, it will probably always be a theme with drugs, I guess. And side effects include headaches, nausea, palpitation, seizures, more common when given too rapidly by intravenous injection. Wow, we finished. Well, so I hope you enjoyed my first ever video. My camera is also flipping my face, which is kind of annoying, but here's my picture of a pumpkin to mark the end of this video, and it's been an hour, which is impressive because there's only like 33, no, there's only like 30 slides, and I don't know how lecturers do this, because I didn't think it's going to take this long. I genuinely thought we could cover everything in 15 minutes. Making this video has proven to me that these things take time to talk through, but I think it will be useful, and I think over time the production of these videos will probably get better. So it's something that maybe I'll put more of an effort in. However, if I've made any mistakes, let me know in the comments. I'm not so narcissistic or egotistical to be like, I don't make mistakes. Obviously, I expect mistakes. So if there's no mistakes here, guys, come on, you can do better. You can find my mistakes. And I have a 9 AM tomorrow, and it's currently 1. So I'm gonna go sleep, guys. And yeah, thank you for watching my video on asthma.